thank you for making this possible and inviting these wonderful speakers here to this webinar with us from around the world, from Jordan, Romania. And here we have now Dr. Mohammed Rashid. Again, I hope I pronounced that somehow correct. Maybe we can do a quick sound check. Can we hear you all right?
Can you hear me, Fabian?
Yes, perfect. Thank you so much.
Excellent, brilliant, excellent, brilliant.
So, I mean, we introduced you before for those that were not there. And again, I can only apologize for the technical difficulties that we are facing today. Like I said before, they are beyond our control. This is a problem with Zoom that some people cannot access here via their telephones. So apologies once again for that. I can honestly only hope that this will not happen again. Yes, thanks for bringing up your lecture. Again, I introduced you before, but a few words. You are a consultant for gastroenterology and hepatology, professor in gastroenterology at the University of Jordan, Amman, and you will be speaking to us about IBS management, reliable treatment options. So over to you, Dr. Mohammed. Thank you so much for being with us.
Thank you very much, Fabian, for the introduction, and I'd like to thank Prof. Dan Dimitrescu for such a wonderful lecture and excellent introduction to my talk. So I would like to start by talking about IBS management and treatment options. So this is my agenda. We're going to talk about approach in the management of IBS. We'll talk about drug therapy in subtypes of IBS, such as IBS-C, and then we move to drug therapy for IBS-D, and then we're going to touch some bases on non-pharmacological approach for this patient, and you can see Dan has alluded to some of the approaches that we could use with our patients. So to prepare for this lecture and to present an evidence-guided medicine, I've looked at so many papers, but the three main guidelines, international communities that I looked at is the American College of Gastroenterology clinical guidelines, which was just published at the American Journal of Gastroenterology in January, so like a few weeks ago. And then we have the NICE guideline, which is the National Institute for Health and Care, which was published initially in 2008, then updated in 2017. Then last but not least, the Canadian guidelines from the Canadian Association of Gastroenterology, which was published in 2019 for the management of irritable bowel syndrome. Now, as we said that, irritable bowel syndrome is quite a broad spectrum of a disease, and we have to establish a doctor-patient relationship. And I'm looking forward to read the book that Prof. Dan has showed us about the doctor relationship as well with the patient. So making a positive diagnosis is always the start of the treatment. Our patient does not want to hear what they don't have. Our patients want to hear what do they have. And that's why some of them go desperately doing food allergy tests or other explanation for their symptoms. They want really to have a positive diagnosis. Doctor, tell me what do I have rather than I don't have. Don't tell me I don't have cancer, I don't have inflammatory bowel disease, I don't have acid-related disorder. They want to know what they have. So always start by the right approach with the patient, doing the necessary investigations. Of course, taking the social history and the psychological history is very important, as Prof. Dan alluded that some of these patients will have some experience in the past. And then once you reach a diagnosis, then you start the journey of treatment. And this
Mohammed,
was,
sorry for jumping in here. Can we check your audio again? That your settings are right with the headphones, which I remember worked a lot better before.
Can you hear me now?
We can hear you. It's just that a couple of people are saying that your sound is very, very far off. So maybe
let me
just to make sure that your headphones are being used.
Let me just double check. Input. Okay.
This is much better, I think.
Yay! Thank you so much for making that possible.
Thank you. Can I start from the beginning then? Okay,
sorry for the interruption. Thank you.
Is this clear now?
Yeah, perfect.
Okay, excellent. All right. So, as I said, I'm gonna number one, I'm gonna look at my approach in the management of IBS. I will talk about drug therapy in IBS-C and drug therapy in IBS-D with diarrhea, and talking about non-pharmacological methods for patients who Prof. Dan just mentioned about. So to present this lecture, I prepared 3 guidelines, which is the most recent guidelines, the one which is the American College of Gastroenterology, which was only published a few weeks ago in January 2021. And then the NICE guidelines, which is the National Institute for Clinical Excellence and Care. It was initially published in 2008 and then updated in 2017. Last but not least, as I said, the Canadian Association of Gastroenterology, which is basically published in 2019. As I said, the most important thing to make a positive diagnosis, and this is where the treatment starts. Patient doesn't want to hear whether they don't have inflammatory bowel disease, peptic ulcer disease, cancer. They want to know what they have. And that's why some of them desperately go for having a food allergy test or try to find an explanation for the symptoms. Once you exhaust all the clinical history, the psychological history, the drug history and everything else, and then you follow the investigation which needs to be done as Prof. Dan mentioned, which is whether it's colonoscopy, CalPro, or CLEC screen, and then you reach the diagnosis of IBS according to Rome criteria. Then you start the treatment or the journey of treating these patients. And this is adapted from the EEW last year or year before. The IBS must be at one stage a multidisciplinary approach. So as I said, you start by diagnosis and explanation, reassurance for the patients. Then you move to a lifestyle, and there was a question before about lifestyle reassurance. Then you move to that next step. I mean, some patients will have enough with this. Say, okay, listen, I don't have anything serious. I'm happy with that. I'll live with it. I can cope with it. I don't need anything else. And then you go up, step up approach about talking about diet, then maybe using some drugs, and then maybe going to the more complex advanced medication that we use. And from a personal experience and from medical trials as well, the more time you spend with your patient, the less will visit you to the clinic and the more improvement you will find with their symptoms. And it's very important that again and again to stress that this is a positive diagnosis. Tell the patient what they have rather than what they don't have. Tell them this is it's not a serious condition, and set up the goals. It's very important to set up the goal. I mean, I always tell my patients, listen, probably I'm not going to cure you. I'm going to care about you, as mentioned previously, but we'll make your life better. We'll make the quality of life better. We'll make you able to function, go to work, study, sleep, etc., etc. So when you direct your treatment for IBS, you look at the most predominant symptoms for the patients. And again, I ask my question directly, directly, what do you want me to do for you? What do you want me to cure? What's the most thing that really interfering with your quality of life? What's making things really miserable for you? Is it diarrhea predominant? And there are some drugs that we're going to talk about. Is it pain predominance? Is it bloatiness and distension, which I think personally is one of the most difficult things to treat? Or is it constipation predominance? And then according to the patient presenting, or I say main symptoms, you direct your treatment. Because even if the patient have multiple symptoms, if you really interfere or improve the most predominant symptoms, then patients probably will feel comfortable, will be satisfied, even if they have a little bit of bloatiness or discomfort left after your treatment. So let's talk about IBS constipation. And fibers is one of the common drugs that you use for constipation. Let me, before start talking about the drugs that we use in IBS, let me compare to you the American and the Canadian. The recent American guidelines was based on one, evidence-based medicine, two, whether this drug has a global benefit for patients with IBS. So for instance, if a drug will treat constipation, but will not treat bloatiness. It will not treat the global symptoms of the patient. It will not be recommended by the American College of Gastroenterology. And that's why you will find sometimes some discrepancy between the different regional guidelines between the Americans and the Canadians. So some drugs will be recommended by the Americans, some guidelines will be recommended by the Canadians, or both. And again, this is to do with the global improvement of the symptoms in the analysis or the controlled trials that have been conducted in the past. So back to constipation, IBS constipation, fibers, which is the soluble fibers, not the unsoluble fibers that we use for patients with IBS. We use around between 25 to 35 grams per day, like oat bran and barley. And there are some few trials about this. There are meta-analysis of 15 randomized controlled trial, almost 1,000 patients. All of them proven to have improvement of the global symptoms and constipation. And that's why there is strong recommendation among the American and the Canadian guidelines of using fibers for IBS-C constipation. So soluble fibers and IBS, dietary fibers can be classified into soluble and unsoluble. The soluble fibers found in vegetables, fruit, oats, cereals, for example, they dissolve in water and they become a soft gel, which is readily fermented. And here you go, all the gases will start forming. And sorry, will be no gas forming. And then the unsoluble fibers does not dissolve in gel or water, is poorly fermented, like the seed, root vegetables, and the cabbage family. And this is the fibers that we don't recommend for patients to be using. So long chain, intermediate viscous soluble or moderately fermented dietary fibers has documented effects in the management of IBS. And again, this has been recommended by the American College of Gastroenterology, and this is an evidence-based medicine for IBS-C. What about polyethylene glycol, which is another laxative we use for constipation? There are few studies only on this. Around 4 studies which showed contributed to 600 patients. There was no improvement on abdominal pain or anorectal tone. So patients, when they go to defecate, they've done on this patient anal manometry, there was no improvement on the pelvic floor dysfunction of this patient, and there was no improvement of feeling of empty evacuation. So as you know, as explained before, patients with IBS constipation, they have, feeling of incomplete evacuation. Maybe patients who have been taking the polyethylene glycol, there was improvement with the constipation. However, the global symptoms of IBS was not improved. So the American and the Canadian guidelines, for this reason, did not recommend using or don't recommend using this drug for IBS constipation. However, there was a very good safety data that these drugs in the long run are good to be used. And this is, sorry, just go back. Okay, sorry. Now, what about chloride channel activator, the lubiprostone? It's prostaglandin analogs. There are few randomized trials on this drug using 8 micrograms PD for almost 1,000 patients versus placebo. There was an improvement, 17% versus 10%. In patients with constipation and global symptoms. So there is a good recommendation to use this drug with the Americans and the Canadian guidelines. And this is a forest plot to look at IBS not improving in randomized controlled trial of lubiprostone versus placebo. And you can see this drug has been used for this. And that's why there is an improvement of constipation and global symptoms. And that's why it's been recommended for using for patients with IBS-C. I have to say we don't have this drug available in Jordan, so we don't use it. We don't have any evidence or practical evidence of using it. Another category of drug called lenactotide or plinaclotide, which is guanylate cyclase agonist. They are basically stimulate the intestinal fluid secretion and the transit time, so they speed your relief and speed the gut motility, and 290 micrograms daily for 12 weeks for around 800 patients been used. And it's been shown that this drug works very well in patients with IBS-C through the two mechanisms that I've mentioned. And this is the multiple studies that showed that, up to 2017 by Yang. And it's been recommended by both the American and the Canadian to use this drug. Tegrisol is one of the 5-hydroxytryptan serotonin 4 receptor agonists. It's basically stimulate the release of neurotransmitters and increase the colonic motility, so it will improve constipation. It also reduce abdominal pain in IBS symptoms and improve the constipation. A few clinical trials, around 11 randomized controlled trials been reviewed, and this drug has been used for almost 3 months among 800 patients in a dose between 2 milligram and 6 milligram BD. And by the way, there was no much difference between the 2 milligram and 6 milligram BD, and this has been effective in IBS constipation. However, this drug may slightly increase the risk of cardiovascular event in females. So it has been to be used cautiously for patients who have more than one cardiovascular risk or women who's above the age of 65. There is a strong recommendation by the American College of Gastroenterology to use this drug. However, the Canadian did not recommend that. What about charcoal? We're talking about charcoal, and thank you, by the way, by EoCarbon for organizing this webinar. And this is a multinational, multi-center, prospective, double-blind, randomized trial, phase 3, which I'm sure you're all aware of it, looking at the use of EoCarbon in patients with irritable bowel syndrome. And across the symptoms, there was increase of the diarrhea, constipation patients, and with the mixed patient, the well-being. So there was significant improvement in all groups with IBS-C, IBS-D, and IBS mixed type. And there are so many drugs in the pipeline for IBS-C. However, I'm gonna stop at here for IBS-C and then move to IBS-D. We're all familiar with the drugs loperamide, which is helpful in stopping the frequency of diarrhea. However, it does not improve the consistency of the diarrhea. And that's why there was no global improvement of the symptoms among clinical trial. So the American and the Canadian were against this drug because it only reduces your frequency, but does not improve your abdominal pain or the diarrhea in terms of consistency. But the frequency, yes, it does. Okay, so loxodilene is an agent that combines a mu opioid receptor agonist and the delta opioid receptor antagonist. And this is one of the drugs that have been used for IBS-D. As you know, morphine receptor agonists will make constipation. Patients who come to hospital who have morphine, they get more constipation than patients who receive different type of painkillers. And this drug has been recommended in a different clinical trials to be used for IBS diarrhea and different clinical trials, as you can see, that favors the use of this drug. Rifaximin, as you know, is a non-absorbable antibiotics. We've been using it in hepatic encephalopathy and recently been used more and more in patients with irritable bowel syndrome with diarrhea. A few double-blind placebo trials that look at the use of rifaximin in almost 12 weeks duration. And most of these trials showed after 2 weeks of treatment, there is almost 40% improvement of the global symptoms. Some of these clinical trials as well needed almost, number need to treat almost 9 patients to get 1 patient improving on rifaximin. So in general, rifaximin has been recommended by all societies to use in IBS diarrhea. There are some concern about development of a Clostridium difficile pseudomembranous colitis in patients who's taking long-term antibiotics. However, this is rare happening. However, it does happen. Personally, I stopped the rifaximin after 2 to 3 months of using, and then maybe give the patient a bit of break and then restart again if the patient have recurrence of the symptoms. What about aldosterone? It's a 5-HT antagonist. A few randomized controlled trial and all reported improvement of the symptoms, like aldosterone or antiemetic drugs that helps in patients who have diarrhea, and they help to decrease the gut transient time. And it's been recommended to use this drug by both society according to evidence-based medicine. Now, all of us know the role of bile salt malabsorption in developing diarrhea, especially patients who have previous surgeries. They will have bile to be deposited in their colon, and this will cause secondary bile salt, and this will create a form of increased load, osmotic load, and this will lead to diarrhea. Or patients who basically have cholecystectomy or hepatobiliary surgeries, they may have an abnormal bile gut cycle, and this will lead to diarrhea. However, the recommendation of the use of this drug, cholestyramine, is only when you prove to patients that they really have a bile salt malabsorption. So you have to do the FCAT, basically, you look of bile salt malabsorption to prove it, and then to use it in this constant. So we don't use this drugs blindly. We use it only when we have a confirmed evidence that this patient have bile salt malabsorption. And usually it is patients who have previous surgery, or you do a form of bile salt studies, and then you confirm the presence of bile salt malabsorption. And there are so many drugs in the pipeline. However, I'm going to stop here for diarrhea. Then what about abdominal pain and bloatiness? I mean, to me personally, I find bloatiness is one of the most difficult symptoms to treat for the patient, because really there is not much you can do in terms of measurement of this severity of bloatiness. And there are so many antispasmodic drugs that we've been using for ages for this. However, the American guidelines does not recommend antispasmodic agent for the use of IBS with abdominal pain. And again, this is for the reason that I've mentioned, because this does not improve the global symptoms of the IBS. However, as you know, there are isothiamine, dicyclothiamine, and all of these drugs can be used for patients who have abdominal pain. However, this has not been recommended by the Americans. However, the Canadian recommend using these drugs. Peppermint oil, as you know, peppermint oil, one of the natural oils that have been used for bloatiness and abdominal pain. It acts as smooth muscle relaxant. It gets rid of the gas as well. And there are a few clinical trials that favors the use of peppermint oil. And this has a very strong recommendation by the American and the Canadian guidelines for using peppermint oil for this purpose, probably because of the improvement of the global symptoms, the bloatiness, the gas, and the abdominal pain, and with the very excellent, as you know, safety data on it. This is briefly, again, going back to eocarbon, which have some essential mint in it, and this would stimulate the evacuation of the gas and reduce the painful contraction and relieve the cramps in the abdomen. The only problem I find with using peppermint oil is heartburn. Because of the relaxation, you'll find that this patient may have more heartburn or acidity or reflux symptom that you can easily treat with, PPI or antacids. And this is again, looking at the study that I presented before on EU carbon, that there are improvement of the abdominal pain and the bowel habits in different categories of IBS. And as you know, in the market, there are a few antispasmodics. I'm not going to go through all of them. I'm sure you're familiar with some of these drugs. So this is the NICE guidelines pathway for maintenance therapy on antispasmodic. Again, it's not been recommended by the Americans or the Canadians. However, NICE do use them for 1 month to be used by the GP. And if there is an improvement, you continue for 6 months and then re-evaluate again. If there is no improvement after 1 month, then you look for different type of a drug. Now, coming to the probiotics question, and this has been discussed before with Prof. Dan. Now, as Prof. Dan said, the clinical trials in probiotics was not very extensive. Most of the trials hold small numbers. It looks promising. However, the problem that you have to combine more than one probiotics. There are a few clinical trials that used only one probiotics. It seems that they are effective in patients with IBS with different strains. However, which strain is more beneficial? I don't think there is still strong evidence of that. This is the proportion of patients who have SIBO, small bowel bacterial overgrowth, in patients with IBS compared to healthy volunteers. And as you know, in IBS, one of the things that we talk about is the equilibrium between the microbiota and the gut bacterium in these patients. And this is some summary of the clinical trials. And overall, the probiotic seems to be working. And in 35 clinical trials, over 4,000 patients. However, some clinical trials did not show any improvement of the symptoms. I personally use probiotics for patients with IBS. Again, 1 of 3 studies, 33% administering monostrain probiotic reported some significant improvement. Some studies, 75% in this multi-analysis, showed multi-strain probiotics. Looks like these drugs are beneficial on the BDFO and the lactobacillus, which is the most common 2 probiotics been used in this clinical trial that has been giving some good results. However, again, the American guidelines does not recommend using probiotics or use it carefully. The Canadian, yes. There is some benefits, but I think we need more clinical trials for that on meta-analysis of so many randomized control trial over, as you can see, 51 randomized trial reviewing almost 6,000 patients, and the evidence is there. However, there is no strong evidence of using probiotics for patients with IBS. However, I do use them. Now, going to the basics, as Prof. Dan said, that this is all a gut-brain axis problem. And one of the things that we look at after taking psychosocial history and different symptoms of the patient, what is the predominant symptoms? Is it anxiety, depression? Is it pain? Is it satiety and bloatiness? And accordingly, we may use the bigger drugs or the drugs that can affect the gut-brain axis to modify the patient's symptoms. However, these drugs have some problems. Patient does not want to have the stigmata of being depressed or anxiety. At least this part of the world in the Middle East and where I live, if you tell patient, I'm gonna give you, let's say, an antidepressant, tricyclic antidepressant or SSRI, and then he goes to the pharmacy and read the leaflet about this, then he will come back. And I remember a patient, writing a review on me on Facebook saying, this doctor, I went to him with a bloatiness, he gave me antidepressant, I'm not crazy, I'm not depressed. And I think it's very important to explain to the patient why you are using this drug. And I always tell my patient, well, I'm not giving you this drug because you're very depressed. We know that this drug works in your condition. So one of the problems of these drugs is the stigmata of using this drug in our area. The second problem we have, they are not a fast-acting drug. I mean, patients who come to you and you give them drug, they expect improvement within 1 or 2 weeks. And I always tell the patient it will take some time. It will take some time for your symptoms to improve. And the third problem is the side effect of the drug, especially, patients who say, I feel myself like a zombie land when I start using, let's say, amitriptyline, etc. I cannot function, and the patient already have bloatiness, has pain, he cannot function, and you give him a drug that make him sleep all the time. Then you have really to be careful how you use these drugs. Antidepressants has been used effectively in this patient over 18 randomized controlled trial. Number need to treat almost 4. In clinical trials, almost 66 improvement of the patient's symptoms. So there is a very strong recommendation among different society to use these drugs. This is from the UGW, how to use antidepressant. You always counsel the patient. I think you should always start with the simple drugs, diet, lifestyle modification, and then negotiate the treatment. You start with small dose and uptitrate it gradually, and the patient ask the patient to come in 6 to 8 weeks time. Then if there is an improvement, you continue and you may optimize your treatment. If the patient doesn't improve, then you may consider switching the class or stopping the drug for another drug. The story of the diet. And again, there are some few questions in the first session about diet. And we all know about food map diet. And the food map diet, as you know, it's been shown that it may improve patients with IBS. Most of the trial was done in Australia. The problem with these clinical trials that they compared patient on a healthy Australian diet and a food map diet. And actually the healthy Australian diet was not the normal diet that patient takes. So maybe there was some bias over there in this clinical trial that they asked patient to be on a healthy diet, which is not the normal diet that me and you will take. And they compared it with the low food map diet, and there was some improvement on this frontier on food map diet. And the way we do it, we recommend low food map diet for 4 to 6 weeks. If the patient improve, then they come back in 6 weeks time, and then we introduce 1 or 2 food map diet over 3 days. And then you can work with your patient in a food diary, how to reintroduce a normal food map to that patient, because low food map diet is not very well tolerated, and patients sometimes doesn't like it. It may be associated with some nutritional deficiency, so you have to be careful how to prescribe it for your patients, and it needs to have a lot of compliance from the patient. And I think in our practice, we ask the dietitian and nutritionist to look after these patients. So few clinical trials, small trials, as you can see, one showed benefit, the 2 others did not show any benefit. And this is the food map that we recommend for patient to eat and avoid. So a long list, and I always ask my patient to go and read about it and see what they can do about the low food map diet. So elimination of diet, everyone's digestion food trigger are different. So basically elimination, what you do, you ask the patient to start taking off some diet or certain things from their food. So this is an elimination diet rather than food map diet. So basically, instead of asking the patient to go on a strict low food map diet, ask the patient to try to eliminate some of the diet that may cause problems to them, okay? And then ask the patient to have a food diary and see what happens. What about gluten? Some patients will improve on a gluten-free diet. However, gluten restriction has not been recommended by the societies unless the patient, of course, have celiac disease. At that time, they don't have IBS, they have celiac disease. So there was no recommendation to ask the patient to go on a gluten-free diet. Again, lactose intolerance, there was no recommendation to restrict milk. However, if milk does cause trouble to the patient, then yes, they can stop it. And I always tell patients when they ask me, what should I eat, what should not eat? I said, make a food diary, see, test yourself, come back and tell me what suits you and what bothers you. So we talked about this. We talked about how certain type of food will cause more exaggeration of the symptoms, hypersensitivity, production of gas, and triggering the whole cycle of IBS. So what you need to do, you need to exclude the gas-producing foods, onions, carrots, raisins, bananas. You know, I mean, to me, I eat bananas. I have no problems, but this was some of the evidence saying that these food have some of the gas-producing elements. This is the nice guidelines for dietary modification, and sorry for poor quality. However, the nice say that always do a lifestyle assessment and dietary modification before you go into the low food map diet, and make sure that the patient doesn't have, you know, gluten, celiac disease, or other type of malabsorption disease or pancreatic disease. And then if this doesn't work, the simple thing, then you go to the food map diet. And again, there was not much enthusiasm about this in the Canadian or the American guidelines about food map diet. That you can try it. There's no strong evidence about it, but you have to be careful about that. I have to admit, I mean, you know, I don't have any experience in CBT, and Jordan, we don't have anybody who's experienced in CBT. Unfortunately, we don't use it. There could be some evidence on it, but as Prof. Dan said, you know, you need to be really having a lot of time, a lot of training to do that. There is no strong evidence about that. However, some patients may require CBT and may benefit from CBT treatment. The more interesting fecal transplant, I mean, as you know, there is a lot of clinical trials about, you know, using fecal transplant in different gut disorders, inflammatory bowel disease, proctitis, and IBS. And again, seems there is lack of evidence that this may be helpful in patients with IBS. Checking with time, almost finished. So going back to the first slide, it's always a multidisciplinary approach. Is always start with simple things, spend time with your patient as much as you can. I think this will treat 50% of the patient, and then go up before you start prescribing drugs, because patients will love drugs. Because if you start patient on drug, it's going to be really difficult to stop this medication for patients with IBS. And I think this is the, to summarize my lecture, this is the nice guidelines for IBS algorithm. As I said, this was published, updated 2017. After you rule out all of other disorders, then you look for lifestyle modification, physical activity, exercise. Then you start targeting the main symptoms of this patient. And this is the Canadian consensus on guidance for management of IBS. Again, you start with fibers. We said about peppermint oil, antispasmodic here, where the American disagree with the Canadians, and then look at the predominant symptoms. This is IBS-D, IBS mixed, or IBS constipation. And there is no recommendation, as I said, for gluten-free, herbal remedies, acupuncture, we did not talk about that, chlorhistamine, polyethylene glycol, or arizolol, or procainamide. And this is to summarize the most of the meta-analysis that was published in the recent 2018 about the different evidence-based medicine on different interaction or different things to be done for patients with IBS. And unfortunately, as you can see, the strong evidence is only for few of them, such as the fiber, the antidepressant, the nucleotide, the blicknitide, as explained in my lecture. And I think with this, I finish my lecture and be happy to take any questions. Hello, Fabian?
I'm here.
You're
Me already?
I'm sorry if I exceeded my time.
No, all good. Thank you so much. That was very insightful. And we already have a couple of questions here coming up. And maybe there seems to be some very specific questions on food. So maybe we start off with that. Is herbal tea or green tea recommended? Also, are citrus or sour foods okay in IBS? So I mean,
Sure.
very specific.
Yeah. I mean, herbal tea is not. I mean, it depends what herbal tea you're talking about. However, there was no recommendation. I mean, herbs is herbs. I mean, you're talking about so many things, different things. So if you're talking about absolutely. So if you're talking about peppermint, it's absolutely fine. You know, you can have peppermint oil, tea is absolutely fine. It helps you. The green tea maybe doesn't help you. I mean, if you look at the guidelines, the American and the Canadian and the NICE guidelines, the only herbal, if you can call it herbal, product that you can use is the peppermint oil and nothing else. However, going back, if it's very difficult to do a clinical trial looking at this herbal medicine. However, peppermint oil, yes. Anything else, no. Citrus food, again, there is no data that it's beneficial or harmful. However, citrus food may cause more heartburn, more acidity. However, again, you know, there is nothing wrong of trying something and see what happens, you know. So I always tell my patients, okay, you try it and tell me what do you think. And then if the patient say, I love it, then, you know, there is no harm of continuing this drug. But we're talking about evidence-based medicine here.
Mixed IBS. You mentioned in your slide also, I mean, also, I think it was the Canadian guidelines that showed probiotics, showed FODMAP, that showed CGT, and all those things that to some extent you agreed with, but there are limitations. So how do you treat IBS mixed?
This is a very important question, Fabian, because, you know, if you're gonna, you know, one shoe doesn't fit all. So if you're gonna say that I'm gonna give a drug, I'm not gonna give you a drug that we're gonna sort out your constipation, your bloatiness, your discomfort, your pain. It's difficult to treat all the symptoms at the same time. So you have to agree with the patients. And I always tell my patients, what is the main problem you're suffering? What do you want me to sort out for you now? This is a journey. This is not going to be sorted out in 1 or 2 visits, okay? So my approach, I never ever give too many drugs at the same time, because 1, you don't know which drug is working, and 2, you don't know whether these drugs is antagonizing each other, because some of these antispasmodics will cause constipation. And if the patient has already constipation, will have more constipation. So basically, when I approach patients with IBS mixed, I always come for the main predominant symptom. There must be predominant symptoms that, you know, causing the symptoms or causing the complaint of the patients. Probiotics is like a general drug. It's used for everything, basically. It can be used for distension, for diarrhea. So there's no harm of throwing probiotics initially. However, I always tell the patients, what's predominant symptoms? If predominant symptom is D, I stick with D. If it's C, I stick with C.
I mean, there's a very specific question here on probiotics about the Nisle 1917. Do you have any experience with that? Any recommendation regarding that strain?
Yeah, I mean, there was some clinical trials about that, but again, the evidence base for this drugs is very poor. I mean, one of these clinical trials is less than 100 patients have been used. So the evidence base for probiotics for these strains are really not strong. However, the general consensus among reading plenty of papers on probiotics that probably the sense is they are useful, as Prof. Dan said. However, we need more clinical trial to prove that. Personally, I use different mixture of probiotics, whatever available. Again, we do have some natural probiotics. Don't forget about it, in natural yogurt. And you know, when you go to the farmers, so I always tell my patients, well, try something more natural and see what happens instead of having the tablets. Do
you recommend yogurt as a treatment for IBS?
Not any yogurt, not the processed yogurt. We have, we are an agricultural country, so we do have some natural yogurts that made at the farms, not processed, not treated. So the probiotics is not killed completely, not chemically
processed too much.
Processed too much. Yeah. So for this, yes, I do recommend that. Yes.
Okay. Very good. I mean, maybe it goes in a similar direction. It's a bit offline, but how do you treat bloating only?
Bloating is very difficult to treat. As I said, most of the patients, especially ladies who come to me, I said, you know, I'm really worried about my shape, my belly. I cannot wear my tight clothes anymore. And I always go with the food and lifestyle habit. And you'll always find, or most of the time, you'll find something precipitating their symptoms. I mean, the way they eat, the way they swallow air, the way they, digest, lifestyle, lack of exercise, etc., etc. And these patients, they are the most common patients that may benefit from diet modification, because they will tell you, I wake up in the morning, I'm absolutely fine. Once I start eating breakfast, then this is where all troubles happen. So in this patient, lifestyle, exercise, then looking at the diet, then I give them something to speed up their gut, their transit time to get more air. I use eocarbon a lot as well for this patient, and I give this patient a lot of exercise. You know, when you eat slowly. Don't swallow a lot of air. Some of this patient will swallow and talk, just breathing exercise, and peppermint oil. Peppermint oil is very useful as well for these patients. Probiotics as well have a role.
Okay. Here we have a very specific question, and since I don't live in Jordan, and maybe it's relevant to some here, is a question about tegaserot. Are you aware of the drug?
I have to say I never used it. It's not available in Jordan. We don't use it. The evidence base for it is very good. I mean, the clinical trials for hundreds and hundreds of patients is absolutely fine. It's been recommended by both the Canadian and the Americans. However, there was some evidence of, I think, ischemic heart disease events and TIAs in patients who have more than one cardiovascular risk factor. So if a patient have diabetes, hypertension, or ischemic heart disease, we don't recommend using it for a simple reason, because it increases the risk of last thing you want to give your patient a stroke while they're coming with you with an IBS, basically.
Okay. You mentioned CGT. I mean, this seems that this intersection between, again, we had this before with Dr. Dan, this intersection between gastroenterology, psychology, psychiatrist. When do you give up? When do you give up and say, I think you better go and see a psychiatrist?
I mean, if I feel, I ask my patient to go and see a psychiatrist if I feel there is really a plus symptoms, and this is plus symptoms is my own making, where patient is really having severe depressive episodes or increased anxiety. If the patient is telling you, listen, I cannot sleep, I cannot function, I cry all night, my whole life is destroyed, been through a traumatic experience. I do use some mental or small scoring system for depression, anxiety. So you can find this on the web everywhere, about quick screening tool for depressive anxiety illness. And if I spot any of this, then I refer this patient to the psychiatrist. One thing. So I never refer a patient to psychiatrist when I give up on, let's say, constipation, bloating, etc., etc. But if I feel there is more to the brain rather than the gut, then I refer this patient. This is one condition. The other condition, when I start using complex antidepressant, complex SSRI drugs, or if I need to combine them, then at this time, I will ask my psychiatric colleagues to help me, because we are not, as a gastroenterologist, expert in that. Maybe my limitation will be a small dose of escitalopram or small dose of amitriptyline. But once I use the more, generous drugs, then, or I have more than one drug, then if I combine drugs, then, or I want to switch class. So switching class as well and combining drugs, I will go with the psychiatrist, or with the patient have some side effect on these drugs. Because, as I said, these drugs can cause a lot of troubles if you don't use them carefully and know the side effect of them. Especially especially the tricyclic antidepressant.
Are there drugs that you use together with antidepressants, or do you say?
I use citalopram. I use citalopram. I use tricyclic antidepressant. I do use a small dose of, let's say, if the patient is having sleeping disorder, like long-acting diazepam, maybe. And this is initially not for a long time. We do have different drugs, like Denexate, or with different manufacturers here in Jordan that I use them. But I always prefer to use combination of something working on the gut and something working on the brain as well. So I don't solely recommend using only antidepressant, or let's say a receptor or brain modifying this drugs for this patient, because at one stage I have to stop this drug. We know that probably at one stage you need to taper your patient off of this treatment. And And this will give hope to the patient that one day I'll be able to stop this drug, before I do that. I mean, some insurance company will even provoke your insurance policy if you take antidepressant for a mortgage or driving a car. So this have a great implication.
I mean, there's a very specific question here. Do you have any opinion about escitalopram versus amitriptyline?
Okay, I mean, amitriptyline, I use it when the patient have pain syndrome. So if I use pain syndrome, if I'm talking about severe pain, and we do have a patient, if you rule out everything, if you rule out inflammatory bowel disease, FMF, I mean, Mediterranean fever, etc., then amitriptyline is an excellent painkiller. It's an excellent drug that I use. And you have to be careful of how you start it. I mean, we do have the 25 milligram here. So I've asked the patient to take half of the tablet and don't take it very late. So in the morning you can function and get up and work. So I really up titrated very, very slowly. So start 12.5, 25, I rarely exceed 50 milligram. If I exceed 50 milligram, then I go to the psychiatrist. So slow dose amitriptyline, and most of my patients, the 20, 25 and 50 milligram will improve. So if the patient have pain, and mainly pain, then I will use amitriptyline. If the patient have more of a depressive disorder, if more their anxiety, depressed, more psychological component, then I use escitalopram. If they have more of a gut predominant disorder with pain, I use amitriptyline.
Okay. Coming back to one of your favorite drugs, peppermint oil, what amount do you use it in?
Well, I asked the patient. It depends on the formulas, to be honest with you. So there are different formulas. I mean, there are some in liquid form, and there is in tablet form. I'm not aware of the exact doses, but usually, let's say chlorperamine or peppermint oil capsule, which is available widely in the UK. We use 1 to 2 capsules 3 times a day. We here have the Colament, which is basically similar formulation. This is a small capsule of peppermint oil. Different concentration, that 3 to 4 times a day. As I said, the only problem with it is causing heartburn and acidity. I think it's a quantity-driven symptom sort of improvement. So you can always ask the patient to increase the dose. It doesn't matter as long as it doesn't give them heartburn or acidity.
We talked a lot about probiotics. What about prebiotics? And do you use them together? Do you see benefits?
Not really. I mean, there is no strong clinical evidence base of prebiotics as well. I don't use them. We don't have them available in Jordan. There are some drugs that have small pre and probiotics, so combination of both. However, there is no evidence that this has been effectively used in IBS.
Okay. Okay. We talked about FODMAP. Is FODMAP used for all types of IBS, IBS-D, IBS-C mixed, or is there certain areas where it works better? Sorry, I'll follow you on that one.
Okay. So cheers. FODMAP is, I think, is the most important use of IBS in patients who have bloatedness, who have discomfort, patient who the gassy abdomen, I call it, the patient who a tympanic abdomen. So patients who suffer from basically bloatedness, distension, mild discomfort, not severe pain, IBS, because changing dietary will always change your bowel habits. So it may cause you constipation or diarrhea, etc., etc. So the idea of FODMAP is that you give a food which is low in things that cause more gas and more stuff in your tummy. So the main thing that I use low FODMAP diet in patients who have a bit of discomfort, but mainly predominant bloatiness, gaseous abdomen.
Some patients use medications that may trigger IBS. First, do you agree with that? And if yes, how can this be managed?
Yes, I mean, it can do that. I mean, it's always cons and pros of what you're using. It depends, what drugs are you using, the need for it. Basically, I see, whether this medication is important for that or not. I always say having one drug is better than having 2 drugs. Having 2 drugs is better than having 3 drugs. So if they can down titrate the medicine, it's absolutely fine. If not, then we can add the IBS sort of treatment. Again, IBS is broad, so tell me what this treatment is causing you. Is it diarrhea, constipation, bloatiness, and sometimes the IBS is related to disease itself rather than the medicine taken by the patients.
Another specific question here: must we suspect microscopic colitis with IBS patients?
Oh, excellent. This is a very good question. I mean, one of the patient to microscopic colitis, as everybody knows, patient can present with diarrhea, change in bowel habits, and abdominal discomfort, especially in women. And patients having any evidence of raised inflammatory markers, calpro, calprotectin, then you should suspect microscopic colitis in this patient, and probably colonoscopy is needed and taking biopsies. I mean, normally, if I do a colonoscopy for a patient to have a chronic diarrhea who I gave up for everything, I always take random colonic biopsies to rule out microscopic colitis. So you must always do that. You must always do microscopic, especially in females, right and left side biopsies to rule out microscopic colitis. We've seen a few of these patients who respond very well to treatment. So yes, patients who have ongoing diarrhea not improving on medications, maybe slightly raised inflammatory markers, CRP, slightly raised calpro, then we must do colonoscopy and random colonic biopsies.
Okay. Melatonin, will it be effective in IBS if there's also a sleep disorder?
Yes. I mean, I think anything that will help your sleep will help your IBS symptoms, because as we said, number one, lifestyle is very important triggering factor for IBS symptoms, whether it's stress, anxiety, lack of sleep, stress disorders. So if any drug that can break the cycle, then absolutely fine. I mean, there is no evidence, direct evidence, looking at randomized controlled trial for melatonin for IBS patients. However, it's been known that patients who go to cognitive behavioral therapy, patients who have a better sleeping pattern, they have improvement of their IBS symptoms. So I think there is an indirect relationship there.
Okay. Dr. Mohammed, looking at the time now as well, I very much appreciate all of your speech. Yeah. And I very much thank you. I'm very grateful that you made it, that we could get together here at this IGES webinar. Thank you so much for all your insights.
Thank you very much.
Thank you for your time.
Thank you very much.
Yeah, this actually then now concludes this